Hi, everyone. Thank you so much for being here today. I think we're going to go ahead and get started. You are at a lunch and learn called Different Plans Towards the Same Destination, Tailoring Treatment to Patient Preferences. We have, I think, a really cool session planned for you all today. I'm going to go through the learning objectives, but before I do that, I'm just going to give you a preview of what we're going to be doing here today, which is going over a fictional case presentation, and then we have three amazing speakers who are going to approach the case from different treatment lenses. So, to get us started, our session objectives are to describe the core principles and clinical applications of at least 3 therapeutic approaches. We do have 3. Compare and contrast how different therapeutic frameworks can be applied to the same clinical case, and identify practical tools and strategies from each approach that can be integrated into real-world clinical practice. Okay. Get started. All right, this is our case. So we were going to print this out for you all, but we ran out of time and also didn't want to print and destroy trees. So keep this in mind as I read it through. It is a little bit long, so I'm going to read it. Both Brooke and I are going to read it out loud and just try to remember, press the save button in your mind. So our fictional person with CF is Jordan. He is 19 years old. Jordan is a 19-year-old Black male who was diagnosed with CF at the age of 16 after years of misdiagnosed and undertreated respiratory and GI symptoms. He presents with increasing anxiety and depression related to the ongoing demands of his treatment regimen, fear of medical complications and declines in health, and distress associated with the upcoming transition to adult medical care. He also expresses feelings of isolation and grief around his late diagnosis and the impact it has had on his adolescence and sense of identity.
Jordan lives with his parents and younger siblings and has historically been academically motivated with a strong peer network. He's currently enrolled as a senior in high school, and his academic performance has declined due to absences and fatigue. In the past year, he's begun to withdraw from enjoyable activities due to the time-consuming nature of CF treatments and the feelings of being different. Jordan is modulator eligible and initiated a trial of ETI upon diagnosis, but he discontinued due to elevated LFTs. Jordan's late diagnosis has resulted in more advanced symptoms and the need for aggressive treatment, leading to physical exhaustion and frustration. Importantly, experiences of racial bias and systemic healthcare disparities were noted by the family during the delayed diagnosis process. For example, despite documented visits over several years to local providers, their requests for more comprehensive testing were dismissed, and they were told the diagnosis was asthma. These experiences contributed to a significant delay in receiving a CF diagnosis, which the family believes would have been identified earlier had their concerns been taken seriously.
Okay, our clinical focus. Jordan has discussed the challenge of accepting his diagnosis and integrating his treatment regimen into his life. The most frequent complaint regarding adherence is that the treatment regimen is overwhelming and all-consuming. Jordan reports recurrent skipped treatments when feeling stressed or when trying to maintain social plans. He also reports worries around disease progression and being a burden to his family, and admits that part of his difficulty establishing a consistent adherence regimen is that each time he engages in CF care, it reminds him of the stress and anxiety he has about CF in general. He stated that sometimes not doing my best is easier than having to think about CF. Jordan has mentioned feeling like he has lost time because of his late diagnosis, and discusses identity confusion related to being a teenager and someone living with a chronic illness. He often shares that he doesn't know who he is anymore and frequently worries about his future. A recurring theme is Jordan's anxiety about the upcoming transition from pediatric to adult CF care. Although the diagnosis is recent, Jordan has quickly developed a sense of trust and comfort with the pediatric care team. The thought of moving into an adult clinic elicits feelings of fear and loss. Jordan's many years of unsolved medical complexities prior to his CF diagnosis were described to be highly traumatic, and the bond he feels with his CF multidisciplinary team is strong. That's it. Okay. So I now am going to introduce our first speaker. Amanda Montgomery has been with Nemours Children's Health in Orlando, Florida, where she works as their CF team social worker and mental health coordinator. She's also a clinical therapist with their psychology division, where she sees youth for varying mental health challenges. Welcome, Amanda.
Hi, everyone. Thank you for joining us for this lunchtime session. And again, thank you all for just inviting me to be a part of this presentation and this complex kid and these different approaches. When we hear this case description of this fictional, I think we all have in our minds a Jordan that lives within our clinics. So a lot of different challenges and really hits home, as I was reflecting, just really can think of definite cases that this applies to. So in regards to disclosures, I do have to share I am part of Vertex's healthcare professional advisory panel, and I do have served in some capacities for podcasts and provided printed materials as part of their Everyday CF program, but also admitting to having some imposter syndrome here today, as I am not an expert in CBT. I do use CBT approaches with my therapy clients. I see my time is split between CF and therapy, and the two don't necessarily always overlap. I do not have CF patients that I routinely see in my therapy caseload, but I am using CBT strategies and principles. I do flex some of that into the in-person interventions that I'm doing with our CF patients in clinic. I was, though, able to be part of a research context in that I was selected to be a CBT interventionist when we were integrating the use of a continuous glucose monitoring device for diabetic patients and helping teens to self-manage that and how they leverage those things. So again, I am not an expert by any means, but I am here to kind of share where I feel CBT might be a useful strategy. So again, I think everybody in this room knows what CBT is, right? Does anybody not know what CBT is? Great, preaching to the choir. So as we think about it, the key aspects to really hone in. Again, this is a psychoeducational heavy focus. So it's letting people know, again, really informing them about that interconnectivity and can be very empowering. It does connect those thoughts and feelings, behaviors, how that drives responses, both in positive directions, but also making them aware of the negative directions historically it has. And it's very skill building. This is active practice. And I think so many times when we think about therapy and we're challenging our young people to think of things differently, like, okay, yeah, that sounds good, but what does that look like? How do I do that? So within CBT, being able to have that active practice both within this session sphere, but also as prescribed homework. So we're all pretty familiar with the CBT triangle, but I like it. Again, it really reinforces and hones into us that true interconnectivity between thoughts and emotions and behaviors. I do like other depictions of the CBT triangle that has more of that spherical kind of circular, because we spin. And, we spin in positive directions, negative directions. One thing might spin the other. So again, a negative intrusive thought might change how we feel and change our behavior. And so as we're looking at imparting education and strategies, how do we, again, control the spin so it's not too fast and it moves in the right direction? So, there is a lot of great empirical support of why CBT would be helpful in any population, but especially within our CF population, right? So It's been demonstrated to be effective across spheres. Mental health, we have been using this for a long time for treatment of depression, for anxiety, for substance abuse, for teenagers, for relational dynamics. We have seen this broach into our chronic illness spheres. As I mentioned, I had done research with diabetics and using it. It has been linked to significant improvements in emotional functioning and perception of quality of life. But in the very inception of our CF mental health guidelines since 2015, CPT was there. So our International Mental Health Guidelines Committee, they recognized what value CBT has already shown and what value it could bring within our sphere. And there has been already in conference such great presentations, including Deborah Friedman, psychologist, her project with the CF CBT pilot trial. Like, how exciting is that going to be to have, again, that another level of that validated measure moving forward for our families? So again, why might this be a good fit for Jordan? So CBT aligns well with, again, the needs of chronic illness. It does have that realistic outlet that can help engage people like Jordan who might be feeling very overwhelmed and not know where to start. Being a late diagnosis, Jordan may feel left out of how to integrate CF into his life, so the psychoeducational component and skill building based on his unique needs and experiences might help him to feel more empowered within a supportive matrix. With his worry of impending transition, time-limited interventions could help build confidence that these are skills that he can learn and grow from within specific timeframes. Having that specific goal orientation can also help him to identify aspects that he can problem solve within the moment versus feeling lost to a future that may or may not be. And finally, that collaborative nature can help reduce feelings of isolation, both within the therapeutic scope, as well as with the change elements, such as tools like behavioral activation, which we'll talk about later. So again, I am not showing you a specific model of step-by-step how we do this. I'm going to be sharing some CBT skills and strategies and principles and how they might apply, again, for our young man. Creating an agenda can help people create order out of perceived chaos, and even within the therapeutic context. So many times I'll have a new patient that'll come in, I don't know what to talk about, I don't know where to start. So for someone like Jordan, he might not have a good frame of reference of really where to start, what would be most important. So having that agenda can help him to feel a little bit more that he doesn't have to have that burden on his own. We will help him to figure that out. He might also feel the negative stigma of counseling in general as a sign of weakness. So CBT at its heart, again, is not a passive discussion or advice giving. Having an agenda is operational. It sets a non-judgmental expectation of what you will be doing together in your set amount of time. It also helps highlight that we might learn best when we experience or, again, practice skills in real time. So ants, they're pretty common. Automatic negative thoughts, not the little bugs that are on the ground. But again, they're common. Everybody has them. These are thoughts that pop up in the situation, and they're not always positive. But because they might be just so ingrained in who and how we've developed to the point of awareness, we don't even really notice how destructive or negative they can be. So, being able to, the longer they kind of sit around, they do become distorted. They can become bigger than where that initial premise can be. And we also have to remember that sometimes automatic negative thoughts have actually come from a real thing somewhere along their journey that, again, left unchallenged, became further distorted. So as we kind of think about these things, if we don't question them, we can digest these as truth. We don't know that they're not true anymore. So, and it can negatively affect, again, going back to that spin, and can be spun by anxious and depressive symptoms. So helping Jordan to increase some awareness of his own automatic negative thoughts might be a very helpful first step. So it kind of leads us into the construct of cognitive restructuring, again, increasing his awareness of these automatic negative thoughts, but also the thinking patterns that correspond with them, which again lead us to the other steps of cognitive restructuring that we'll get to. But one of the basic, quick, easy ways to help Jordan be aware of that is through the use of a CBT thought record. So this is an example of one. It's not necessarily my favorite, but it kind of hits to the key points of, again, what was the situation, what was the thought that popped up, and helping him to be aware of what mood or emotion might correspond with it. Now, usually when I'm introducing this concept with somebody, we'll only maybe hit the first 3 boxes. I don't expect them to intuitively know what to do with the next steps, but at least helps us to start the process. As we start to capture these negative thoughts, we kind of start to trap them because there are common thought traps, themes that we will see in these thought processes. All or nothing thinking. We know this. Black or white. Absolutes. Perfectionism. Might be overgeneralizing. How many times do we get that very broad response and we know that there's a lot of gray in the middle of there? Catastrophe, worst case scenario, again, a little bit more of that all or nothing thinking, that again, it can't go one way or another. Labeling, I'm the worst, he's jerk, oh, that sucks, right? We know that there's more to that, but helping him to know what is behind that thought. Jumping to conclusions, mind reading, fortune telling, dangers of assuming. How many people like to use, I like to use that phrase, the dangers of assuming. What are they, folks? You have the chance of guessing wrong. I live in pediatrics, folks. I can't use the word ass all the time. Okay. Should statements, again, that kind of absolute thinking that we want to supportively challenges it. It doesn't have to be a should. It could, helping reframe. And again, emotional reasoning, kind of doing our thoughts driven by emotion, but not realizing that that's that driving force. So what could be thought traps that Jordan is experiencing. As we know from our outline, he has defined adherence as very overwhelming and all-consuming. Could these be examples of all or nothing thinking or overgeneralization? We've heard him also say, my CF is a burden or a stressor for me and my family. Emotional reasoning, again, driven by the emotion. And not knowing who I am anymore and worry for his future, catastrophizing. He's lost his sense of identity. So again, as we go into this next step of cognitive restructuring, let's attack them. Let's challenge them. When you start thinking of them, it might be through a supportive exploration with questions like, how likely is this to happen? How could I cope if it did happen? Have I ever coped with something like this before and what helped? A lot of times our young people, while they may not know what to do for themselves, they're really good at helping other people. So one way you might try to kind of help them to bring that awareness is, what would you tell a loved one if they were thinking like this? What do you think your loved one might say to you? And we do know from the construct, he does have a support. He does have that family infrastructure, that can be some positive momentum to gain with this. Other supportive ways to challenge it, again, might be, am I blaming myself for something that I'm not 100% in control of? Could I look at this at a different way that might be kinder to myself? So again, we might go back to the thought record and help him to fill in the additional boxes, again, within that supportive environment of the session, and encourage him to have it as a homework for ongoing work. So as we go into our next set of tool sets, we look at adaptive thinking. We can teach Jordan to how to be his own detective, because all good detectives collect evidence to solve their crimes, right? Why can't Jordan? Many times what is thought to be evidence is actually a falsehood or not the complete picture. We think about helping him to learn the difference between rational or irrational thoughts. Now, in one of my therapy clients, he was a little younger, so one way that we kind of talked about him identifying the difference is we talked about, is there a pink unicorn outside the window? No. Okay, so that's an irrational thought. Is there a pillow on my couch? Well, yeah, irrational thought. So anytime we would continue the conversation, I'm like, wait, did that sound like a pink unicorn to you? Yeah, it was. So again, helping to build the discrepancy. Again, I work in pediatrics, but sometimes a young adult might like that reference too, because it helps them to know that this actually can be a simpler concept. It doesn't have to be overly complicated. So again, after the detective work, he might need help in distinguishing, again, what's the difference between thoughts and feelings? Asking questions about like, okay, you were having, you were shaking, you were kind of having what sounds like symptoms of a panic attack. What were you thinking? Oh, well, I was scared. Okay, is scared a thought or is it a feeling? Oh, wait, that's a feeling. Okay, so what thoughts popped in your head as you were feeling scared? Helping them to, again, expand that thought and not just go into an assumption. We might also need guidance into help to generate helpful thoughts. So this is where I love positive mantras. It kind of goes into our thought of coping cards, what things help, because sometimes when we're in these moments, we can't think clearly. So we need something else to do it for us. So I was joking with my colleagues before I walked in. I needed that power today because I was feeling a little nervous. So Bob Marley's 3 Little Birds, every little thing is gonna be all right. I also have on my screensaver, you are allowed to imagine the best case scenario. So again, when we have coping cards or we have these little positive mantras, little things to kind of get us, a lot of times they can help us to move out of that negative and intrusive thought into at least a clear thinking headspace. I love doing decisional balances. I don't know how many of you folks do, but every decision, even the decision to do nothing, comes with goods and not so goods. And what might be good for me may not be good for somebody else. And what is good today may not be good in the up days and coming weeks, because you're making the best, so you're teaching that as you're making this decision, you're making it within the context of what's going on in that moment. And you might find out later that wasn't the right thing, but you can't judge yourself for what hasn't happened yet. What is the here and the now? So in the exercise, it respects that decision-making is not always easy and straightforward. Writing the goods and not so goods down, and I do really prefer when people can write these down, but sometimes, just with how the flow is, we have to brainstorm. If I have other people in my session, I might include like a parent. So if Jordan came with, his mom, I might have her help us to generate the decisional balance, because sometimes people think of different ideas. But I really like writing it down because it's more symbolic. It's real when it's written down on a piece of paper. But writing down the goods and not so goods gives you the chance to visualize and see and analyze the information without getting it clogged up in your head with your thoughts and your feelings. It might also help to identify and challenge maybe some hidden ants that he might not have been consciously aware of in that moment. So as I think about Jordan, I might use this exercise as we're looking about treatments and his perception of treatment burden. What might be really weighing into his sense of value? If treatments are a constant reminder of his CF, maybe kind of helping him to think through, well, what are the pros and cons of this? As you hear from other people, as you've heard in your own experience, and have him see that on paper. There we go. I also like scaling. When I was in my first training with scaling, I'm like, oh, this is kind of a corny concept, right? Looking at a ruler, readiness rulers, right? We think about with motivational interviewing. But it does help, when you kind of take some step and really think about what a ruler or scaling can do for you, it really kind of helps you to have that unique perspective. So like with scaling, it respects that what I might view as a 6 doesn't match what maybe you view as a 6, but we still know where that lives in a level of importance, because we know with a 6 there's higher numbers, but there's also lower numbers. And it doesn't matter where you are, where I am, I know and I can respect where that's at. What I also love, you can use scaling within various different contexts. You can use it for motivation to change. You can use it in terms of severity. As we talk about gauging anxiety levels or depression levels, if he's feeling a 7 and we do a change element, whether it's some relaxation training, whether it is an exercise, and after that, and he's able to say, oh, I actually feel like a 4. I still feel it, but maybe not as intense. And bringing that awareness to him. because then that might be an aha moment for him, like, oh, wait, I can feel it, but I don't have to feel it as intense. So I am starting to run out of time, but as we go into other concepts, we might be doing mindfulness and relaxation techniques. I do like this comment about mindfulness within CBT, that sometimes it can be more helpful to identify an ant and acknowledge it, but also choose to let it go. Not every automatic negative thought needs to have a way to debunk it, but it's to accept it and give it less power to us in the moment. Now, again, within the formula of CBT sessions, you can be practicing it together, how to do some deep breathing, doing some diaphragmatic or some belly breathing. You can do a guided image or exercise. You can do gratitude reflections. And again, it's not just here's a piece of paper, these things might be helpful, you're doing it together. I know when I have done yoga classes, I can watch a video. But that's very passive to me. If I'm in a class and somebody's saying, go Amanda, or oh, nope, not bending, I am much more, it gives me better form and technique, and then I have more confidence when I do it outside. So again, this is another one of my favorite strategies, and I think it's my last strategy. Sure, it might be my last strategy. Anyway, so as we think about behavioral activation, when we go into these cycles of anxiety and depression, we tend to isolate, we tend to avoid, so our behavior is that way, but our thinking becomes that way. Our feelings become that way. So with behavioral activation, it helps to empower a young person to try to claim something back. So, and that is engaging activities either that they want to do, they feel that they should, and again, know that they want to, but they just have no clue how to do it. So again, activities can be things that they used to enjoy doing, something related to their values, a sense of social connectedness. But the most important aspect of this, it has to be, again, operational. It has to be specific, it has to be observable, and it has to be measurable. Why? Because noticing any bit of change, even if it's the tiniest bit, is a step forward. And many times when people get trapped in these next steps, they can't see that step forward. And this also can give us an opportunity to elicit support from the friends and family that he knows are in his community. Again, he has a great support system. He's feeling that isolation. This might give him and them something that they can do to try to change that mentality. So as we think about what might be behavioral activation goals for Jordan, it might be to reconnect with friends. So as I'm doing this problem-solving exercise with him, I am looking at our question words. Okay, what could that be? Who could it be with? When could that be? Where could that be? And then the most important is wait, why do you want to do this again? So for Jordan, it might be helping him to make it more specific as setting up a time once a week to online game with friends. And that might be simple and low-balling fruit for him, but it's something more than he's doing now. When? Of course, as CS healthcare teams, we also want them to prioritize their health. We want them to do something with this. And I think sometimes team members, if they are part, I faced this with when we were doing motivational interviewing at our clinic. Well, that's not the goal I wanted them to work on, right? But being where they are, person and environment, getting in treatment, best treatments, maybe that is something that he wants to work on. Again, going through our who, what, when, and how, it might be doing just one treatment when he gets home right from school, because that's what works for him and that feels achievable. Is it ideal? No. But again, any step forward is still a step forward. And that's my time. Thank you guys so very much.
Thank you, Amanda. I have the pleasure to introduce Dr. Christopher Drescher, who is a psychologist and professor in the Department of Psychiatry and Health Behavior in the Medical College of Georgia at Augusta University Adult Cystic Fibrosis Center, and is the outgoing chair of the CFF Education Committee. Dr. Drescher specializes using dialectical behavioral therapy and acceptance and commitment therapy for mood and anxiety disorders. His scholarship spans a range of topics, including positive youth development, LGBTQ mental health, dialectical behavioral therapy, and acceptance and commitment therapy. Help me welcome him.
All right. Good afternoon, everyone. Let's see here. All right, so I'm excited to talk to you all a little bit about ACT, acceptance and commitment therapy today. So I'll do the same poll Amanda did. Who would say they're like at least moderately comfortable using ACT? Okay, maybe a third of people. All right, so some of you are familiar with it. Some of you, maybe this is newer to you, and that's cool too. I don't have any disclosures right now. So let me just start by talking a little bit about what ACT is. So ACT was developed by Stephen Hayes and colleagues, and really the goal of this intervention is to increase psychological flexibility. And that's a little bit different than most interventions and sort of traditional CBT, where the goal is really symptom reduction. So when we talk about psychological flexibility, we're talking about the ability to contact the present moment fully and engage in behaviors that serve one's values. If symptom reduction happens as part of that, that's awesome. That's just not necessarily where everything is driving in therapy. And in general, we do see that when people become more psychologically flexible, that is related with decreased symptoms of anxiety and depression. There's different ways to think about processes in ACT, but I like this 3 pillars approach. It kind of simplifies it a little bit more than the hexaflex, if you've seen that before. And that's really talking about ACT helping us become open, aware, and active. And I'm going to sort of frame my discussion of ACT with CF using those 3 areas going forward, those 3 pillars. So if I want to break down ACT a little bit more, it's going to emphasize different techniques around thoughts than CBT. We're not going to use cognitive restructuring. We're going to focus on cognitive diffusion, and I'll give some examples of what that can look like, as well as mindfulness as ways to disentangle and get some distance between ourselves and unhelpful thoughts, and be able to experience the present moment fully. The kind of key difference between CBT, there's really a lot of overlap, I think, in practice between ACT and CBT, but if we're drawing a little bit of a distinction for the purpose of this talk, is that the focus is on accepting and making space for painful inner experiences rather than trying to change them. And the reason that we do that in ACT is because we're trying to help people reduce behavioral avoidance. In other words, we're trying to help people be able to move towards their values and goals even when painful things might come up. And hopefully this makes a little bit of intuitive sense. If you've ever had something important to you that you've worked on, which I know you all have, obviously, there's been difficulties, there's been pain, there's been stress that's a part of that, and you needed some way to still move towards what was important to you, and that's what ACT is really concerned with. Why use ACT with CF? Why? Obviously, we have other interventions, so why do we think this would be something useful in CF? There's a lot of painful experiences in CF, even with all the advances that we've made. Health-related fears, sadness over limitations related to illness, panic when we're having trouble breathing, and a new problem like maybe survivor's guilt over the idea that not everyone got to benefit from the treatments I'm benefiting from. And when we try to avoid those difficult thoughts or inner experiences, that can lead to a lot of different problems, but specifically treatment avoidance. And that's something we kind of saw a little bit about in Jordan's case. It's got a focus and ACT on we want to have a meaningful life despite these painful inner experiences. So we're going to take that as pain is mandatory, pain is going to be part of life, and that's going to be part of our assumptions in ACT. But you can still have a life that's meaningful to you. It was designed to be transdiagnostic, so we don't have to worry too much if someone's fitting into a specific DSM diagnosis category. That's not the way ACT is really framed. And it's designed to tackle complex issues and some of these existential issues that come up in cystic fibrosis when we think about life and our time here. And it can also be delivered briefly. So the ACT with CF protocol was 6 sessions, which seems apparently is the magic number because all the CBT protocols are also 6 sessions. But there is a pain protocol that was presented that's only 3 sessions, so we'll have to work on that. I'm getting it down. This has been specifically evaluated in the CF population. ACT with CF had an RCT with an active control of supportive psychotherapy, and it was found to be helpful over and above supportive psychotherapy. It had good acceptability in the CF population, and there was some trends that indicated it could help with treatment adherence. It might be particularly helpful for patients that were a little bit more physically ill. Okay, so let's talk about those 3 pillars a little bit more, try to give some specific guidelines and or some specific strategies that you can use within each of those 3 pillars. So the active pillar, this is where we are using values as guides to action. So it's actually kind of picks up where Amanda left off with behavioral activation in a lot of ways. So first, before I go into like specific little exercises you can do, this is something that can be assessed in clinic often just with a couple of questions. So who and what is important to you? That's a great opening question I like to do with anyone I'm working with. And I also love the question, if your life could be about something, what do you want it to be about? Man, that cuts right to the heart of the matter. You can't hide from that question. And I can't answer it for you either. So I think that puts important issues in the room right away. You can also do some more formal exercises to get at this. So one exercise you can do is say that you're going to have a 30th birthday party. So I picked a 30th birthday party for Jordan. He's 19. Sometimes you do this exercise, you can say a 70th birthday party or a 90th birthday party, right? Aging with CF. But you can pick something closer if that feels like that might be overwhelming. So let's say it's your 30th birthday party. What will the people at your birthday party say right now if they all got up and made speeches about you? And anyone can be at this birthday party, by the way, like living, dead, people you haven't met yet, they can all be at this 30th birthday party. What are they going to say about you and who you are based on how you're living your life currently? And what do you want people to say about you? So you're starting to get at a couple important points here from an ACT perspective. You're getting at the person's values, who they put there tells you a little bit about who's meaningful to them, and then what they say tells you a lot about what's meaningful to them and what they want their legacy to be, what they want their life to be about. And if there's a big gap between what they think people would say right now and what they want people to say at their 30th birthday party, that helps you understand if there's kind of a discrepancy and if there's a need for some specific actions to kind of bring them more towards their values. And, after you gather some of these values, that can actually be a nice way to flow into behavioral activation. And that's committed action would be the word they use in ACT, but it looks very similar. I would say Jordan, from our case study, he's already telling us a lot about his values without any of those specific questions being asked. A lot of times values are linked to pain, right? If we care about something and it's not going the way we want it to, that is where it hurts. So there's a sense of isolation that really indicates he values friendships and social connection. He has a fear of transition to the adult team. He really values the relationship he's had with his pediatric team and being able to be vulnerable and open with them. He's had a history of academic motivation and doing well. I say that could indicate a value around learning or achievement. We want to be careful about assuming, I think around school specifically, that people care about it just because they do well. There can be a lot of pressure from parents or other people to do well in school, even if we don't care about it much. And sometimes we do well just to avoid getting in trouble. And that's not what we're looking for in ACT. In fact, sometimes I'll say, would you still care about this if no one even knew you were doing well in school? If they say yes, that's probably a value. If they say no, it's appliance. And he likely values something about this idea of being an adolescent. He feels like he's missed out on his adolescence. So we want to understand what has he felt like he's missed out on there. Was it just having fun, being in the moment, certain activities, milestones? We want to understand that because there's probably some values there. And navigating these values is going to require flexibility, both from Jordan and from his healthcare team. So again, a little bit of overlap with CBT here. I would say we are going to try to look at the pros and cons of how he's living his life in terms of his values. And one of the contrasts we're really going to draw is about short-term versus long-term pros and cons. A lot of behaviors make sense in the short term, and they move us kind of away from painful things, or maybe even towards our values in the short term, but when we look in the long term, they cause more pain and often get in the way of moving towards our values. So for example, skipping out on treatments may make him feel better in the short term. He may feel a little less anxious, but in the long term, it's actually getting in the way of being able to spend time with his friends, do things he wants to in his life. And I think the flexibility required from us as a team is, and I'm probably not supposed to say this, but you might be willing to negotiate a little bit more on your expectations, right? How much, when is it okay to miss a treatment sometimes to do something important with your friends? Giving yourself permission to do that rather than sort of impulsively avoiding treatments because you don't feel like it in the moment. And I also think it's really important as you explore these things that you acknowledge the grief. You know, we don't try to say, well, you know, you shouldn't be upset about that it took so long to be diagnosed. You're diagnosed now. That's the important thing. We're going to take care of you. That's super invalidating. We need to acknowledge, you know, why it's been hard for him and try to understand what's important to him about these things he feels like he's missed out on. And I also just wanted to call out equality as a value. I think that's showing up here for both his family and Jordan. So there may be a broad, you know, he feels like he has, and it seems like, I know it's a fake case, but it seems like in the case that he really was unfortunately, there were delays in his healthcare because of racial bias and systemic biases in healthcare. And we need to acknowledge that. And there may be specific actions that he would want to take around trying to improve his sense of equity in his own healthcare or for others. So looking for pathways there as well. All right, so that was the active part around values and action. Now let's think about the open part. The open part of ACT is about how we relate to our inner world. So I put a little more explanation in here for open and aware because I think active, most people get that one. What you care about, moving towards it, I think we can understand that one. For the openness, this is where we, you know, think about letting go, allowing, willingness of inner experience. Taking an accepting, non-judgmental, non-reactive stance towards our thoughts and feelings. And here's where kind of detachment or diffusion comes in. So fusion is where we feel really tightly associated with a thought or a feeling. Diffusion is where we're holding that lightly, like we might hold a butterfly. So some of the things as a therapist we might do to try to promote openness include labeling thoughts as thoughts, feelings as feelings. So you're having the thought that you're a burden on your family. So you're feeling disappointed about missing out on things during high school. We're just nothing more, nothing less. We're just labeling things as they are. We can start to use some language, again, to differentiate the person from their thoughts. So what is your mind telling you right now? And how will it work if you go with that? I'm not going to try to argue about whether it's true or not, but is this going to be helpful for you to go with that thought? And you know, when these feelings show up, how do you usually respond to them? How does that work for you? So it's all about thinking about noticing, allowing, and then workability. So that's where the skillful part comes in. Some specific exercises we might use here. Metaphor, ACT is big on metaphors. I'm not going to go through a million, but one is the finger trap exercise. So you can see the finger trap there. Most of us have played with these, got them as like a party favor or something, or from Putt-Putt with our tickets. So we talk about, you know, as you try to pull away from that painful thing in your life, if we label one finger as maybe a painful feeling or thought or something about CF we don't like, as we try to pull away from it, we only become more and more trapped. In fact, the only way to get out of that trap is to push, to lean in to this thing that's painful or difficult. So it's a metaphor for kind of acceptance and letting go of the struggle with painful thoughts or feelings. So some opportunities, I think, for openness with Jordan. One is to do some diffusion work around language. So there were certain words that kind of jumped off the page for me. So he feels like a burden. He feels like he's lost time. You can do different things in ACT to try to take those thoughts less seriously as the truth and treat them just as thoughts. So milk, milk, milk is an exercise where you say the same word over and over again as fast as you can for 30 seconds. So if I did that with him, I'd be like, burn, 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 burn. It starts to just kind of turn into nothingness syllables in your mouth. And you can actually have a different reaction to it in the future when that thought is coming up. And you can also do, when you have built trust in a relationship, things like saying difficult thoughts in funny voices or singing them, like, I have lost a lot of time, lot of time, lot of time. I always do Mary Had a Little Lamb because I can fit everything in there. And I'm an incredible singer. And so the idea with that is that thought's going to come up, but now you have some new learning with it and some learning where you're not so tightly held to it. There's also a lot of opportunities, I think, for acceptance around the painful feelings that are coming up around treatments and engaging with the team. And again, you're going back to workability and can you make space? Can you allow? Can you actually lean into some of that anxiety you're feeling and still show up for a clinic appointment and still do a VEST treatment? What would it be like if you made space for that? And then finally, we'll talk about awareness. So this is really about being in the present moment, not caught up in the past or the future. So here we're talking about noticing, observing, naming, showing up to whatever is there, and really orienting often towards the pain rather than trying to avoid it. So there's a couple of different ways we can do that. Mindfulness was mentioned in CBT. An ACT mindfulness activity might look something like this. You start by just focusing on your breathing. That one can be kind of interesting in CF, right? Because breath is something that can have a lot of thoughts and feelings around it. I have found that people are still able to do this. It's RT approved. I asked the RTs, can we do deep breathing? Yes, that's fine. That's great. They might do better if they practice that. So, and then you really just bring your awareness to your inner sensations and acknowledge them and not necessarily change them. So we're just practicing, again, awareness to those things. If I wanted to practice that with Jordan, I would do a mindfulness activity like that. And I might also consider drop anchor mindfulness skill, which is similar to the mindfulness that I just showed you there, but it would also be focused on simultaneously noticing yourself in the room, noticing that the therapist is in the room or on the telehealth call with you. That's one that can keep people a little bit more grounded if they have a trauma history. Sometimes mindfulness with people with a trauma history can be a little bit overwhelming. And another practice I like to do with folks as they are working on, again, getting aware of things without necessarily being caught up in their thoughts and feelings in a moment is noticing your inner experiences and noticing how those are different at different times. So for Jordan, we could say, I want you to kind of think about yourself now and notice what you're feeling and what you're thinking, maybe things you're struggling with. And then I want you to think back to when you were working with the PEDS team and how you were thinking and feeling. And maybe even imagine your face. You can imagine what the clinic room looked like. And then I want you to think back to before you got diagnosed, maybe when you were in the hospital and what you were thinking and when you're feeling. And if you can even remember back maybe to earlier on when you weren't having health problems, and go through that and notice that your thoughts and your feelings, those were different at each time point. And yet you were the same Jordan. You were the same Jordan throughout all those different inner experiences. So you're not really your thoughts and feelings. That's not who Jordan is, just like it's not who Chris is, right? You are the person that's able to notice and observe those things. That sort of observer self is the through line. And we could even imagine on your 30th birthday, what thoughts and feelings do you think you'll be having? And they'll probably be different than what you're having now. Again, that's to make it, we're not running away from any of those thoughts and feelings. We're aware of them, we're noticing them, but we are getting some distance. So that is one way that ACT might look with Jordan, and I'll be happy to talk about that more in the Q&A.
Thank you so much. I'm going to introduce our next speaker. Before I do, I wanted to say, so far, we've had 2 speakers sing for us. So I'm really crossing my fingers that Dr. Marsak also sings, so he can be 3 for 3. But we'll see. Dr. Megan Marsak is a pediatric psychologist, tenured professor, and division chief of psychology in the Department of Pediatrics at the University of Kentucky. She serves as the associate director for the Center for Pediatric Traumatic Stress. Dr. Marsak is a leader in the field of pediatric medical traumatic stress, having published approximately 75 academic articles, 12 chapters, blogs in Psychology Today, and a book for parents to help support their children through medical care and care for themselves. Afraid of the Doctor, Every Parent's Guide to Preventing and Managing Medical Trauma. Oh, it's impressive. Welcome. Yes.
Okay, so 2 skills I don't have include technology and singing. And so I regret to inform you all that there will be no song tunes unless I don't know, go a little wild on my extra Diet Coke that I had, and you get a fun show from that. But thank you all for joining us today. This has been a really great session. I've really enjoyed getting to hear my colleagues present about this case as well. No one has fallen asleep yet. I've looked, I've checked, so my colleagues have done great. I'm going to try to continue preventing the food coma up here, but we'll see where we get. I'm going to talk a little bit about trauma-informed care and taking a trauma-informed approach to Jordan's caring case. I think that we already talked about, I don't know if we talked about disclosures. There's my disclosure about the book that my colleague mentioned here. So just thinking a little bit about a trauma-informed approach, I'm going to mostly talk about trauma-focused CBT, but just also thinking about the consideration that we can take a trauma-informed care approach no matter what kind of modality that we're practicing in to support our kids and families. And we can take a trauma-informed approach both in clinical care as mental health providers as well as healthcare providers and partnering with our teams. So even in the work that my colleagues already presented, I even heard some trauma-informed care things that they were saying in their care, even though they weren't necessarily making it trauma-focused therapy necessarily. And so when we think about that trauma-informed care piece, we can think about realizing how common it is. And so for those of you who may have been at some of the mental health work throughout the conference, there's been a lot of conversations around medical traumatic stress, both in pediatric and adults. And so we know that this is something that's super common in our population. Also knowing what we're bringing in as providers, I cannot say trauma-informed care without talking about ourselves. So what are we bringing to the table too, and making sure that we're aware of what we're carrying in so that we're paying attention to how our work kind of connects to our patients that we're serving to. Figuring out about recognizing signs and symptoms of emotional trauma. And so even if our patients are presenting with anxiety and depression, also thinking about could there also be some other trauma contributing in there and making sure we know what to look for in that way. And then responding and presenting with trying to prevent re-traumatization. So if you were in one of our medical trauma workshops, where I presented this slide earlier, and just thinking again really broadly around when we're thinking about trauma and caring for our kids and families, what's the basics? And I think both in what Amanda and Chris presented, they're definitely talking about, collaborating, empowering their patients, ensuring that gender and cultural issues are addressed, thinking about historical racism that folks have maybe experienced before they landed in our lap, building that trust, making sure our patients feel safe. And so no matter what modality we're practicing in, and if we're taking a trauma-informed approach, we're kind of thinking about all of these, both in an individual perspective for our kids and our families, as well as a systems approach. So thinking about and tying more directly to medical traumatic stress. So if we're going to start to conceptualize part of what Jordan is presenting with as having potential medical traumatic stress reactions, these are really kind of the emotional and physical responses to the medical care and the medical condition that they're having. These are not limited only to patients. We know we see medical traumatic stress in siblings and parents as well. And we didn't talk too much in the case about what Jordan's caregivers might be presenting with also. But if we're thinking about it from a trauma lens, trauma perspective, we want to be assessing the whole family. And that's my own definition, emotional reactions to the scary medical stuff. And scary defined by our patients, not defined by us as providers. I think we've seen a lot of this data already. In a new study that we are right now looking at some data, we found about 10 to 17% of kiddos reporting significant medical traumatic symptoms. Those 100% overlapped with anxiety. So all of our kids that had medical traumatic symptoms also presented with significant anxiety. So showing some kind of comorbid overlaps, such that if we're seeing kids with significant anxiety, we want to take a look to make sure that there's not also additional trauma symptoms there. So again, one of the things that's really important when we're taking a trauma-informed care approach is to look at the assessment and think about like what are the things we want to look at. When we look at trauma, just like we would with our historical, more kind of longer term, what we've known from trauma, physical abuse, sexual abuse, military exposures, all of those kinds of things, there's these clusters of symptoms. And so we would be looking at this in the context of medical care as well. The other thing we look at this when we're treating patients like Jordan is not only what has emerged as potential trauma reactions from what he's come in with, but what was already there or what's in his other part of his life that also might be contributing to having trauma symptoms. So we'll go through these specifically for Jordan in a minute. I want to thank Amanda for doing such a beautiful job on the CBT model, because that makes this part really, really easy to present. So just thinking about when we think about trauma-focused CBT, we're just really adding that trauma piece in as part of the event. And we know that having exposure to trauma events and having traumatic stress reactions interplays with everything. So an exposure to an event can affect the way we see the world, affect our automatic thoughts, affect the way that we feel, and affect the way we take actions. And so thinking about that, if you're really comfortable with the CBT model but haven't done as much trauma-focused care, thinking about how do you interface that trauma piece into the work that you're doing as part of CBT. So this, the MUSC has a beautiful training. You can go online and look if you want to get more training in this on trauma-focused CBT. Most of this work was derived out of what we think of our more traditional traumas around like child abuse, sexual violence, domestic violence. So most of the work and the research is derived around there, but is applicable to individuals with chronic health conditions. This is a beautiful outline, and you might tailor this, again, depending on your patient and what would fit in, but thinking about a lot of psychoeducation, just like CBT. This one, again, if you're working with kids, you're probably going to do some parenting sessions and try to get parents in a good place too to be able to communicate with their child around things. For Jordan and in a 19-year-old, that's going to depend on the family. So for I'm sure some of you who work with young adults, they're still joined at the hip with their parents and caregivers, and they want their parents involved. For others, they will not come to therapy if their parent will be involved at all. So kind of figuring out for that child. So this can be, implemented in the case of where you've got family-focused care or just individual care as well. So thinking again, when we think about Jordan and figuring out from a trauma-focused perception, where are we going to start? What is present? So we think through kind of the different clusters of symptoms. He's presenting with some re-experiencing, having intrusive thoughts about how the late diagnosis of CF affected him. So those things are popping in his mind. He's thinking about it when he doesn't want to think about it. Remembering not being believed, not being taken seriously. Things like looking at avoidance. So in Jordan's case, there was a lot of avoidance mixed in there. And we know that avoidance is particularly problematic because if you're behaviorally avoiding, that can really mess up your compliance with your care and really affect your health over time. That can really affect your ability to have strong, trusting relationships with your medical team as well. And so thinking about what does that look like. We have seen that, and I've had patients tell me directly, I don't want to do my vest. It makes me remember I have CF, and I don't want to think about having CF. It becomes an actual trauma trigger. So they do their vest, their whole body flips into that fight or flight because they actually get triggered from some of their treatments. And so when we're thinking about approaching care, if their treatment is actually serving as a trauma trigger, thinking about how are we going to treat them such that we're addressing their responses to these trauma exposures so that we don't avoid care. For Jordan, he definitely had alterations in cognitions and mood, anxiety about his medical treatments and medical complications. He has depression popping up, some of that why me, life isn't fair, some of those things popping to line, and then that increased arousal, having that elevated distress at medical appointments or when thinking about CF. We often see, particularly in this age cohort, you got your young adults, even more prevalent for males, but also for females, is that body sensation, right? So sometimes we're not able to put in words, sometimes we're not able to kind of label how we feel or how we think, but what we see it in is in our vital signs or in our kind of reactions or our panic reactions in that way. And so thinking about and doing a full assessment will help us tailor where we want to start with treatment. When we do assessments with trauma-focused work, we want to also look at strengths. So what is already there that we can build on? And so for Jordan, we know he had a strong social support system from his family. He had also had some strong peer relationships that maybe have been kind of a little bit messed up with his current medical care, but it's something that we could potentially fall back on and rebuild. Even though he had mistrust of the medical system, given his journey, he had developed a trusting relationship with the CF medical team. He's got some academic motivation in there and had some previous involvement in activities that we might be able to re-engage. I think that thinking about a couple of those pieces, one of the things we know that's most protective in trauma is strong social support. So if you've got a kid, family, adult, anybody that you're treating that's got a social support system, any way we can scaffold and build that into as part of our treatment can help be protective over time. So then again, thinking about the assessment, what are some contributing thoughts that are popping out? I think, Chris, you might have used this one too, like it's too overwhelming for me to handle. This is my fault. Why don't they listen to me? What if the doctor stopped believing? So you start to kind of see like, what are these different thoughts that are kind of popping up? One of the things that I think is also really important when we're working with CBT or TFCBT in the context of chronic illness is that sometimes the thoughts are realistic and true. Like, what if I die? What if I don't make it to, what if I have to have a lung transplant? And if you're watching, they're markers, and that what if is maybe true. So one of the things that we do sometimes when we're doing TFCBT is think about shifting that from realistic to not realistic to helpful and not helpful. So, okay, that could happen. Is that thought helping you? If that thought's not helping you, what can we do to pivot around that as well? Looking at some of the contributing behaviors. So what is contributing to some of his distress? He's avoiding treatments, makes him feel worse, makes him feel guilty. And so, you start to see that all in that model. Avoiding asking the medical team questions, avoiding difficult thoughts. So again, as we're planning out how are we going to care for him, we're thinking about what are the different symptoms that are presenting. The other thing that I think both my colleagues shared is like setting the goals and mutual goals with the patient. And so thinking about how are we going to decrease this distress related to CF and his treatment such that he can get what he wants done, and how do we increase compliance with treatment. The increased compliance with treatment is tricky because if your Jordan is buying in, awesome. If that's just a secret medical team goal or a parent goal, but not the teenager goal, we have to figure out what is a different definition of that might help move us towards that. We think about barriers right as we're goal planning. And so, 100% compliance might not be realistic if the goals are too big. So again, I think, I can't remember which one of you said, what's the teeniest change? Amanda, thank you. Like if there's just one tiny change, if you're going from doing your treatments from, 0 times a week to 1 time a week, that we get credit for. And so looking and breaking down like baby steps, we want success. We want people to achieve their goals. A little bit of figuring out, is there a difference? I assumed maybe there would be in this case, though I didn't have enough information, but around how do the parents want, like what do the parents want versus what does Jordan want, and how do we navigate that? So getting that right at the beginning and figuring out how they're going to be involved. Really thinking about that mistrust in the medical system and actually looking at it as potential trauma as well. So are there biases that actually serve as racial trauma for him and his family? Did he experience those elsewhere? Are they not just in the medical system? And so keeping that in our conceptualization, because those reactions are going to help us figure out how to best take care of him and treat him. So just kind of walking through, so what would we do with Jordan here? Our first is absolutely psychoeducation, same as CBT, but what we would do really is thinking about the trauma reactions. I think one of the things that's been most powerful for many of our kids and families is when you explain what medical traumatic stress is, and you start to describe the symptoms, not just to the teen or the young adult, but sometimes even to the parents, oh, and many people have said, I thought I was crazy. Like, I thought I was losing my mind. Other people must not experience this. But once you start to, and especially if you have any like handouts, if you've put it on paper, it must happen for other people. And so then it's like something else to be like, oh, or here's a book on this. And like, oh, veterans from the war experience this. Like, this is the level of what your body is doing, and really doing that education, that normalizing and that kind of highlighting can really take a huge reduction in distress just there sometimes. Ranking the most distressing symptoms. So early on in treatment planning, figuring out where does the patient want to start. So what's bothering Jordan the most, and figuring out we're going to start there. Sometimes we have a lot of challenges with some of our young adults being able to, in the moment when they're trauma triggered, identify thoughts. So even like in session, if you're taking like a cognitive approach, and you're like, yeah, no, I know that thought's not helpful, or I know I need to pivot. That when it's happening, where they're presenting for their blood work, they go blank. It's fight or flight. And they're like, I just go blank. I'm not thinking anything. And they can't. So thinking about if those are the trauma reactions that they're having, thinking about behaviorally, what do we do? So maybe we start in the behavior box instead of starting in the cognitive box. Similar to CBT, and ACT, we use some things like diaphragmatic breathing, again, depending on the patient with CF, if that's comfortable for them. If it's causing pain, of course, we're going to skip that or modify that. Progressive muscle relaxation, imagery, mindfulness, all of those kinds of things tailored. We usually give a suite of things that they can pick from. And I find often a number of our young adults will pick the progressive muscle relaxation, especially if they're athletes, because they're used to like training their bodies. And if you can frame it as training your bodies because you're training yourself to relax your muscles, that's a really good way to engage. So we don't always do all these things in order. We kind of figure out what might be the stickiest for that individual and modify it that way. For imagery, a lot of times we'll have them create their own imagery. So pick your own, make your own script, figure out what that looks like for you, those kinds of things. We definitely will spend time labeling emotions and identifying trauma triggers and symptoms. So just labeling something like, oh yeah, that's trauma symptom. Okay, I see you, I hear you. You're not welcome here, but here we are. So just kind of labeling it out loud and practicing that can be really helpful. Figuring out, again, cognitive restructuring, just like we would do with CBT work. Trauma narratives can be dicey. The really, really important thing that if you take any trauma-informed training, if you haven't, is that you have a skilled provider guiding through trauma narratives. If you do trauma narratives where you are reinforcing the story, symptoms can get worse. So the key with the trauma narratives is that we're helping the patient shape their story and working to find those thoughts that are scattered in that are not helpful and reframing it so they're retelling their own story over time. If you're just rehashing traumatic things over and over again, that can increase distress for patients with trauma, with PTSD. Some people love trauma narratives, some patients absolutely not. So you can kind of, you're modifying it and figuring out for that patient what works. One of the things that I think has been most beautiful when we've had successful trauma narratives is it will often take people that are all up in their medical care, all up in their CF, can't think about anything else except CF, and it will help them put it in its place and shift more to like life. So it's not all, I'm not just CF, I am a patient who has CF or an individual who has CF, and here's the rest of my life. So those trauma narratives can be very powerful in kind of putting it in its place. In vivo exposure, for Jordan, this would be starting to have him meet the adult team, maybe having the peds and the adult team together, really engaging people together to try to help with that transition. And then talking to him about safety and getting his opinion about, you've had this experience with mistrust with the medical system for good reasons over time. What can we do to kind of increase that safety over time? We would also be in TFCBT, we'd be collaborating with the medical team as well. One thing that often happens for our patients that have really, really strong anxiety reactions or trauma reactions is they get labeled as difficult, non-compliant, oppositional rather than anxious. I know I have like several memories in my head of these conversations I've had with a couple of nurses over time when I'm like, no, like they're terrified. They're like, what? And especially these big, strong boys. These big, strong teenage boys, and they're not supposed to be afraid in our culture. That's kind of where we're at, and men too. I mean, I can't tell you how many of my colleagues are like, you'd take me down with a needle. I mean, they might be doctors, and they're like, I'm not getting that shot. I'm like, dude, we got to talk about that. But so thinking about, conceptualizing for the medical team, and when the medical team understands this is from fear, it shifts the way everybody interacts together. And looking at, sometimes we also can adapt. And so for some of our kiddos that might be affected by noncompliance, to have them come and do additional monitoring from the medical team. I've had patients before where they will not do their treatments until 2 weeks before every medical appointment. And then suddenly they're doing all their treatments. And so if that's a strategy, and if it's financially feasible, if the family can manage it, sometimes we might increase those check-ins because then it increases the compliance over time. Our team then also, if we do trauma-informed care with our team, then they can reinforce the messages. They can reinforce, oh yeah, no, lots of my patients experience this. This is what this is called, and kind of reinforce that so it's not just coming from the mental health providers. Sometimes the teams can help us shift treatment measurements. I think one of you also talked about that. I think it was you, Amanda, maybe, about, can we shift things a little bit, and then help to find connections. All right, I think that brings us to the question part of our talk.
I'd like to invite the speakers to come up to the table. And we can go ahead and start with any questions from the audience. Thank you so much.
Is this your water bottle?
A comment and then a question. So one of the comments was that we know that trauma results from that feeling of not having any sort of sense of control. And so when we're talking about helpful versus unhelpful thoughts, sometimes I phrase it with my patients as what's an action thought that you can do, what's something that you can have control over. And that sometimes feels more tangible for them. So that's just a little tip. Also, I have been trying very hard to modify my ways to get my teenagers who know everything how to practice relaxation skills. So we'll do it in session and they will, graciously play along with me, but then they're not practicing and following up at home. So my question is, am I going to continue doing that in session with them, recognizing the value of, hey, you're not sleeping, this isn't happening for you, but all of these will be helped with these relaxation techniques? Or do I just keep kind of passively mentioning it and recommending it and saying, I know I talk about deep breathing a lot, but it is really important. Like, how do you guys manage that?
Yeah, sure. Am
You
I
don't
on?
have to press talk.
Do I?
You don't have to.
Oh, you don't have to. Okay. Like any skill you're asking them to practice, I think it actually comes back to what's important to you and why you would want to do that. So getting some buy-in from them, like, I have relaxation skills, like, is that something that you might want? I'm going to be selling them on it like a little devil's advocate, motivational interviewing, because if they're not bought in, I agree. As my former mentor told me, if you don't want to go to Cleveland, it doesn't matter what mode of transportation I'm offering. So you have to get that buy-in to start. That's what I would think about.
Yeah, I think sometimes I also present things as like, here's 3 things we could try. Which one you want to try? Tell me if it fails. Then you come back, be like, that was a big fail. I'm like, all right, did you actually try it? Okay, so it fit. So totally fine. And then, giving them control. But I still generally introduce the skills if I can, unless they're totally like not doing that. And then let them kind of take it and lead it from there.
I think you can also bridge it into just assigning homework, right? And especially, I guess, I'm peds, right? So when I'm talking to my teens and I'm like, oh, it's homework. I don't want to do that. So again, just kind of having that curious conversation. I remember last time, we did, some breathing exercises. Were you able to use it? No, I didn't think about it. And so just curious, no offense, because not everything works for everybody. Again, normalizing that different people need different strategies. Was there a reason? And so, because again, I don't want to keep teaching a skill also that they're not going to use. I don't know why you picked on Cleveland, but that's okay. But
It's my mentor.
But again, if it's not
I'm from
everything works for
Cleveland.
every person. So I don't need to waste their time or my time. I want something that's going to work for you. And do you have a different idea, right? So, and I loved when you were talking like giving an option of different things, because then that allows them to have a little bit more control and autonomy. And isn't that what we're doing? We're trying to empower people that they can find what works for them.
Thank you.
Hi, is this working? Okay. So this is for everybody, but Dr. Marsek, you touched on the people where their trauma is really showing up in their body, or possibly, some images. And I've got a couple people post-transplant and with some real developmental invalidating experiences where their sense of safety is kind of non-existent and so emotionally dysregulated when they get triggered and can't identify thoughts. And so maybe re-experiencing, all of a sudden they're back there and they find it really hard to tolerate. And when they re-experience, it can impact them for days. That's what they're telling me. And so I'm just trying to move into this area of how best to be of help for them. And so even getting pointed in a good direction or a tip, I know this could probably be a whole visit. And I think my own anxiety around exposure work when they're telling me like how debilitating it is, when they get triggered. Any thoughts about that?
Yeah, we do a lot of education around the relationship between anxiety and avoidance. And so we know that if you avoid, it's going to decrease your anxiety in the moment, right? It's a great strategy because then you're not going to have the thing that's going to trigger you.
Yeah.
But then over time it builds and it gives anxiety power over time. And so just a lot of anxiety around or education around, okay, what is that relationship between the anxiety and the avoidance? And like, can you start to get control over your anxiety by managing the avoidance? I think if it's that impairing too, like we do recommend things like medication evaluations. So, because sometimes the trauma triggers are so substantial that the skills, like we're too elevated to use the skills. And so at times that's a time that we might be like, okay, if it's days, or if you can't come to clinic because it's that substantial, those are probably times we're also going to reach out and say, hey, can we get some other medication evaluations as well?
Yeah.
Along the way.
Yeah.
And then for me, there's like, the exposure therapists they are awesome at sitting in there and doing the distress and tolerating. I'm a peds person too, so I can't do I personally, it does not fit my personal style to do exposure without the coping strategies.
Right.
So I'm very big on building the coping strategies and scaffolding with this exposure. I'm not saying that that's the right way, and there's different data on that. It might not be the right way, but for me with peds, like I am not somebody who can sit through exposure therapy in that level of distress. So I think you too, as a therapist, you have to kind of figure out what fits for you.
Yeah, I guess one more thought, like I've had a patient, we're considering them even trialing like a propranolol to see what it's like to go to a visit and not have all those symptoms like going on, like the heart racing and the dizziness and the shortness of breath, to see what happens, with their thoughts. I don't know if what people's thoughts might be on doing something like that.
Thoughts on that? I mean, I think there's some data they've done some propranolol trials, I think, with kids with injuries or maybe adults with injuries. So you could look at that data. I don't know the data well.
Yeah.
And like can't recommend like medication wise. I know at times in some of our like needle phobia patients, one of the things we try to do is work with the medical team, and if it's appropriate, to have some kind of medication in there while they're building the skills. The idea is hopefully they wouldn't need that over time because then they're learning and it's not as scary. But I don't know about that medication in particular at all.
Yeah. All right. Thank you.
I was going to say, we have a kiddo that had a lot of medical trauma, and we just like couldn't get throat swabs anymore. And I encouraged our team to try prescribing something so that he could have a few good visits and then build the skills. And so they ended up giving a low dose of hydroxyzine, and that worked really well, and they didn't have the concerns about it being addictive and things like that. And then he did that for 2 or 3 visits. And then the last visit he came and he hadn't taken anything. He like sat there like a champ, opened
Love
his
it.
mouth, did the throat swab.
Awesome.
So I don't think every kid needs medication, but I think, so I feel like there is a place for it with the really, really traumatized
Yeah.
ones. I also wanted to know if CF Foundation still had, or if there's any places still doing ACT training for CF.
Yes, we are. We definitely still have the manual available. We have training videos actually available, so you can go back and review those. And I think we're probably going to do additional trainings in the future as well. If you just want to email me, I'd be happy to kind of get you those resources. Yeah, awesome. Thanks.
I'm just curious, and I'm not sure of the use with kids. You guys can clarify this for me, but maybe with adolescents and young adults and adults. I work in a pediatric clinic, but I haven't heard very much about brain spotting or EMDR in this setting. And myself, I've done brain spotting, and it was very successful for me. So it makes me wonder, I really don't know the application for children, if it's ever been done with them, but I haven't heard those two practices mentioned at all in this conference. And I was just curious if there's any thoughts about that.
Okay. They're looking at me. So I'm not trained in EMDR myself, and I think that there is some emerging data for some helpfulness in teenagers or older kiddos with trauma, but I don't know that data very well. Does anyone know that? Does anyone in? I know, I've talked to some of our adolescent medicine therapists that at times speak very highly of it, and I've asked them about the data because data person. So I think that there is some emerging data in using it in EMDR for trauma reactions in adolescents. I probably wouldn't use it in peds myself developmentally, but more research to be done for sure.
Based on it really coming down to exposure, is sort of the.
That's my opinion. I don't know. So I appreciate you sharing your opinion on that.
I think all of you mentioned mindfulness and a question around what if the hesitancy is kind of the idea of mindfulness being kind of too woo-woo? Like, how do you approach that with somebody?
I think it's important you define mindfulness within the work you're doing with the patient. So mindfulness is one of those, is becoming more of like a pop psych term. Everybody's talking about mindfulness to make $1 million or whatever. Like mindfulness isn't everything. So you need to say like, what do I mean when I'm saying mindfulness? What does this look like within our work? Is that something you'd be willing to give a try? So I think it's important to kind of give some of that, context for how you're going to use it and why you're going to use it. If the person has a lot of preconceived notions about it, you have to be willing to talk to them about it.
I agree. I like it. It all depends on your own perspective and how you sell it. I found that this has helped for other people. I'm wondering if this could help for you. So, and again, especially for teenagers, they don't necessarily care if it worked for me, but if they know that it has helped maybe some other patients in clinic and they had a response, sometimes they're open to it. And what I have found with some of those resistant, that once they try it, they're like, oh, that wasn't that bad. So again, I think a lot depends on also how you sell it.
Sometimes we teach it as grounding too. Like we don't even use the word mindfulness, but like your 5 senses, like just ground, especially for trauma, like ground back into the moment. And I would say I am terrible personally at mindfulness. So I identify with everyone who says they can't do. I don't know. I need more training or practice on that myself as a person.
That's what every time you practice, right? That's what mindfulness is.
I know.
It's not about,
I'm not practicing,
not about
Chris.
perfection.
I'm not practicing.
Strengthening that mindfulness muscle.
Yes. I'm like, oh, okay.
So working with kids and adolescents, I have to explain mindfulness frequently, and I usually talk about it just being in the moment right now. But we also, Diane Gayhart does a mindfulness for chocolate lovers, so she goes.
Oh, wait now.
She's in.
There's a video. And she really just goes through eating a piece of chocolate, like you start with it in your hand, you feel how heavy it is, you feel the texture of the wrapper, all of that, you smell it, and then you slowly unwrap it. And so it really is like going through step by step. So I will explain it that way to kids, or I'll talk about eating the best cheeseburger you've ever ate. Like, I need you to describe it to me in excruciating detail. Like, that's mindfulness. And so when you describe it that way, it feels less, and it feels more like, oh, hey, like I can talk about a cheeseburger. So
Mindfulness for chocolate lovers.
Let's say,
Everybody
did you
check it
bring that chocolate that you were describing with you? Because,
We could practice right now.
okay, sorry. I'm very distracted.
Just bring yourself back to the moment.
like,
Just notice. And,
So our case, Jordan was a 19-year-old. Just wondering, Megan, for you, how would you kind of adapt any of the strategies you were suggesting for a younger kiddo?
I think we follow the same model for the younger kiddos and just kind of adapt it more developmentally down, give specific examples. For the cognitive work with our younger kids, we often use more mottos and mantras and sometimes involve the parents in figuring out kind of what is the motto for the different moments. We do a lot more structured things if we're finding like trauma triggers, like to like be like, okay, if you have this procedure coming up, we make a whole plan, like a very specific plan. So it's very concrete and put like the very specific coping behaviors in through everything. That's all I got right now. You guys have any ideas?
how to modify your approach.
Yeah.
Another thing that Megan taught me is for the trauma narrative specifically is like you do like a PowerPoint presentation with pictures instead of actually writing out a narrative. Is another way to developmentally adapt that. Yes.
Sometimes we'll do things with music too, like or make music playlists to represent different pieces of things, which you can use all that with adults too. Some adults prefer, I've had some older teens that like the PowerPoint picture versus the like actual writing out of things too.
Well, I think, especially for some teens who might be mature in really other ways, but really kind of stuck in developmental stages, that kind of helps to be where they're at and normalizing that maybe they have missed being able to develop the skill younger, but it's okay to learn this. It's a helpful thing to learn. So, and you did find a way to bring music into this, by the way.
I did.
I wasn't going to sing. Found a way to
sing.
add music.
I've been learning a lot about K-pop Demon Hunters from my patients, quite a lot, and I still have not sung that song one time. My patients will sing. I will dance with them. I just will not. I draw the line at singing.
I actually had a small co with CF do his kind of trauma narrative as a comic strip, and he really enjoyed that. And like he would put his coping thoughts and like the big, he was very into art and would do like big POW boxes with his coping thoughts, and it was a really fun intervention to do, and he really enjoyed that.
Love that.
I had a teenage patient accidentally do her trauma narrative through her college essay. And so she was writing about her disordered eating and her experience with GI issues and all of that. And she like, as she was revising it, like she wasn't doing it with me, and she came to me the next session and she's like, can I just tell you about this? And I was like, oh my goodness, you just did your own therapy, you don't even need me anymore. But as she was revising it and talking with like having her parents read it, she was like doing the in vivo, and she was like, really like getting into it and processing it and changing her relationship to it. And so there's a lot of different ways that you can do it that you don't really realize you're doing it.
What I love about both of those examples, it pulled on something that had a high value to the individual, right? Again, an artist get to be able, and whenever a kid, someone you're working with has a secret skill, when you have ways to introduce that, again, to be able to draw, to create it to music. When, again, college applications, I have a high anxiety young lady that we're similarly going with it, and somehow she has different medical traumas and high anxiety, but she's also has an obsession with macaroons. And so in our last conversation, we were talking about making that comparison of making macaroon. I I don't know how she's blending it, but it sounds beautiful and I can't wait to read it. But again, whenever you're able to tie in those personal, again, it becomes ends of one. And so then that's their investment is higher because they have their own connectivity. So I love that both of you gave examples of that.
I think that's all the time we have for questions. So if y'all please help me thank our wonderful presenters. And we'll see you at the plenary.